get started here because some of the panelists have flights to catch after this. My name is Julianne Hirsch. I'm the founder and president of Syapse. We provide a precision medicine platform to help integrate genomics into routine medical care. And I have the pleasure of moderating the panel today. So what we're going to do is have mostly a discussion, and then I wanted to leave about 15 or 20 minutes at the end for us to have questions and audience interaction. So the thrust of this panel is improving patient care through data and analytics. And one thing that's very interesting about this panel is that you actually have representatives from the physician and treatment side. You have a representative from the payer side. You have a representative from the data and consulting side, and a representative from the analytics provider side. So interestingly, you're going to get a number of different related perspectives on this industry. Hopefully all of this will come together and make sense at the end. And then of course you have the perspective of the startup founder getting into this industry. So what I'm going to do is, rather than going through doing an introduction, I'm just going to let each panelist introduce themselves. So we'll start off with Sanjay.
Hi there, my name is Deloitte. I'll ask you a couple of questions, especially the guys who are filling in their phones. All right, so I'm Sanjay, Joshi. I'm a life sciences geek at UPMC. I've been there, done that pretty much with every modality there is, radiology to cardiology, genomics, proteomics, et cetera, et cetera. Thanks. Thanks for being here.
I'm Julie Buchanan. I'm from UPMC Health Plan in Pittsburgh, Pennsylvania. I'm the Director of Quality Analytics there, where I have a team of about 15 analysts who work on finding ways to improve patient care from the payer perspective. Just to give you a little short background on UPMC, we have about 1.2 million covered lives in our health plan. And we do cover a variety of products, including commercial insurance, Medicaid, Medicare, children's health insurance product, special needs product, and vision-only and a dental-only product.
Thank you. I'm Anwer with Deloitte Consulting. No, we're not here to do your taxes. We focus on the other side of the house. I'm actually one of the leaders in our commissioning practice, where we help payers, health plans, providers, pharmaceutical companies really understand how clinical data and analytics are used in the creation and basic application of solutions in healthcare and improving outcomes.
I'm Aenor Sawyer from UCSF. I am a provider, I'm an orthopedist, but I'm also involved in leading strategic relations for the Center for Digital Health Innovation, which we have at UCSF now, and we have an internal accelerator in digital health. Trying to create fertile soil for frontline innovators, because we think it's important to have them at the table. Also trying to provide more opportunities to partner with internal and external innovators and provide evaluation processes to outside startups as well as internal. And also working very hard on interoperability piece as well as education. So these are different pillars within our Center for Digital Health Innovation. And very happy to be here. We have a large healthcare delivery system. So we have digital health all the way from clinical informatics down to implantable nanosensors that we're evaluating as well as.
So the topic today is a bit broad and can go in many directions. So the first thing that I wanted to ask each of the panelists to talk about is one or two specific areas that they're personally involved in where they're trying to improve patient care through analytics. So we'll just start down the line.
So on the patient care side, I used to work at Children's Hospital many years ago. And this story is actually pretty valid today. I used to also be on the Deloitte working in the mid-90s, before it actually merged with HL7. And the story is that this is where genomics is today. It's a new format. We're trying to figure out, other than the simpler things that the physician down the end here takes care of on a daily basis, how do you bring these new formats? And what's surprising is it takes the same amount of time for a research clinical protocol, quote unquote, to become a production clinical protocol, as much time as you want a BC, which is about 3.5 years, 4 years. And the question, DICOM started off as an open source platform as well, digital imaging and communications in medicine. But as soon as it hit the production side, what was very interesting that happened was that every radiology manufacturer looked at DICOM a little differently. And I think we're going to get into this space of what I call continuous integration. And the story that I want to say is, so Children's Hospital at the University of Washington Medical Center, we're the only medical center in a 5-state area. And I think the issue of integration for a telemedicine platform happened really well. But the larger context of the story I'm going to relate is the law and medical practice. So I think in the mid-90s, late 90s, it was $1 million a mile for fiber. And you had what was called radiology shoving an elephant down a garden hose. And I think genomics is the same story. And I also think that they will always remain separate. I don't think the twain shall meet. There will be separate rails that will be integrated in companies like what Syapse is doing. But the story is that the project failed not because the technology was really good. The project failed because the audience that was both treating the patient and giving the care did not understand if the physician crossed state boundaries to treat the patient or the patient crossed state boundaries to come and get treated. I don't think that's still being resolved, so I would urge every one of you to write your congressman or woman. It is public information and marketing that helped me. Andy, who was from the White House and done the human services. So we as citizens need to be involved as well. Let me shut up there. So.
Okay, from the insurer side, we, believe it or not, actually don't want to raise premiums. We have a very invested interest on the health and wellness of our members. So to that end, we do a lot with a massive amount of data to try to empower the member and help them along and help the providers along with their care. We have a very unique, different view than a physician would because we pay all the claims that are coming in. So for example, a member could be on vacation and they could have treatment for something at a hospital 2 states over. The physician might never know, but from the insurer we see it because we have to pay all the claims. We see all of the visits for the PCP, the specialists, all of the tests. So part of our job is we feel, to feed that information back to the primary care in a way to try to help enable more of a patient-centered medical home and coordination of care. So we're really focused deeply on coordination of care right now. We also do some things that, on an analytical level, that now have become basic, but I don't know if they're necessarily basic to everyone else. So I'm just curious out there in the audience, if do you get calls from your health insurer? Do you get mailings to tell you when things are due, that type of thing? Does anyone get that? Yeah, so some. Okay, so it's actually not as easy as it sounds because we're dealing with all hospital billing data. It's very difficult actually for us to get real clinical data. So we're living in the world of ICD codes, CPT codes, revenue codes, link codes for lab mappings. So what we have to do is we have to find a standardized platform to bring that all in. So just using an example, we have several women care initiatives in our quality department. So we want to make sure that all of our members get their mammograms and get their cervical cancer screenings. However, when a provider bills for a mammogram or a cervical cancer screening, there are various different CPT codes that they can bill under, procedure codes, different levels of care, ICDs. So how do we know as the insurer what is really a mammogram? You have to really take the data through, or a diagnosis. How many diagnoses are there for diabetes? So what is considered diabetes from a billing perspective? So we mine a massive amount of data, and we have standard definitions that we use to support all of our initiatives. So we do many things like, you recommend to get your mammogram over 40 every 27 months. So we will call our members and tell them and try to, when we get them on the phone, we'll actually try to schedule the mammogram, and then we will give that feedback back to the provider. So a lot of our preventive care methods work like this, and part of our core business is to then integrate the provider at the primary care level back into the care.
So just building on your point, as a consulting firm, we basically do what our clients ask us to do. And typically, I will give you 2 examples. So the one client, which is using patient data to improve quality of care, is saying, well, we want to improve quality of care, absolutely, but we want to help reduce costs for the organization. So one of the things that sort of near and dear to me has been building sort of what we call a readmission analyzer solution, and looking at avoidable readmissions within both a clinical and a payer setting. So we actually started out for this particular client looking at claims data. And we looked at patterns across the chronic disease areas and identified, reasons that were spiking. So looking first at anomalies, and then looking at, related correlations of different treatment patterns, looking at variability in treatment patterns, and essentially came up with, looking at about a roughly 50% just on the claims data, saying 50% of these readmissions were avoidable. So they should not have happened, and they cost you as a payer, or mostly, but also now as a provider as well, X millions of dollars. When we added in the clinical data and commingled it with the payer financial data, we actually found 85% were avoidable. So this study was very compelling, and we had the executives of the particular client say, well, this is interesting. We've always tracked readmissions sort of as a departmental function. So, either in the emergency room, which is your typical, also in the chronic disease areas, cancer, cardiology, and so forth. But when we really looked at across all of it, we started to notice that most of these readmissions happened for 2 reasons. And they were avoidable because, one, the patient did not fill their script. So we found that was the biggest reason. They went home, either they couldn't afford to fill the script, or they were just too lazy. They never actually went to fill the prescription. And obviously, over a period of time, they weren't taking a medication, they were readmitted. The other one that we found is that it was related to another incident. So these were false positives. We basically found that they were readmitted, so somebody went in with a diagnosis, went home, 3 weeks later, fell down, broke their arm, were readmitted, totally unrelated, and were justifiable. So I think that was one example of where you're looking at monitoring costs and using techniques around data mining and visualization and just looking at patterns of the data to actually identify cost savings opportunities, as well as looking at the better workflow. Now that was the second part of my data quality and data governance.
And the ability to analyze and algorithmically drive certain things. I just think that's a big piece that we need to keep saying. It's great we can collect data, and it's great we can even analyze it. Ultimately, we want to make people's lives better, and we want to do it at lower cost. So these are some of the things that we're working on. We're working on in the arena of clinical trial innovations, for instance. So one of our projects is the Healthy Heart Initiative, which is the digital version of Framingham study, and we've really already recruited patients through using social media platforms and creative internet solutions. Recruited more patients in a year than were in 10 years in Framingham. And I think each of the examples that we put out there just tells us that we're leveraging technologies and capabilities that we haven't had before. The ability to layer on top of our physiologically and clinically collected data, consumer analytics data. We actually didn't really know that we could look at the use of a cell phone and predict a depressive slide. And I think we're going to get more and more information by layering on disparate types of data we've never had the opportunity before. As long as we're constantly critiquing the quality of the data and how it becomes something that we can make a choice about to make our lives better. I'll stop there.
So one of the big challenges with all this is obviously the implementation, whether it is changing physician and patient behavior, whether it's getting data from legacy systems, as some of the questions in previous panels observed. So I guess just starting with Aenor, it doesn't say on the sheet that you all received, but you're actually a physician. You actually see patients in the clinic. You're on the front lines. I guess just starting with you, how do we go about fitting the work that we all want to do into the physician workflow so that this is truly embraced and adopted on the hospital level?
Well, that's a great question, and it brings me to another model that we're working with at UCSF, and we've got committees on bringing genomic data into the clinical care loop so it's visualizable and actionable again. And one example of that is MS BioScreen, which is a platform for robust multiple sclerosis database, probably the most robust in the world. And taking the data, genomic functional scores, some novel imaging studies, the ability to take multiple data points and bring them out of the clinical research database into the clinical care discussion for shared decision-making between patient and provider by putting it in a dashboard that's very user-friendly and where you can compare apples to apples. So imagine if you're an MS patient where your course is relapsing and remitting and they're offering you these trial type of medications and you don't even know what your prognosis is. You have no way to compare it. Your physician, we anecdotally try this anyway. We say, well, I remember someone who looked like you and they did this. But as we get better at plotting the population database behind it and putting your data on top of it and pulling out the variables we want to compare, ultimately it'll be more like looking at a height and weight curve when you take your child into the pediatrician. We're right now at observational analytics with that, but we want to move to predictive and eventually prescriptive analytics with that. But the idea is to get the data into a usable form, in a contextualized form, but into the conversation between the patient and their family even, or themselves, but between the patient and the provider when that step is necessary.
So speaking of getting data into usable forms, Anwer and Sanjay, you both are at the front lines of dealing with this, whether it's on behalf of clients or selling analytics systems into the industry. Do you find that there are tremendous difficulties, as big as people say, truly getting data out of EMRs and other systems? Or is this a bit of an overblown issue and it's just clever engineering? What's your experience?
Yeah, I don't think it's a technical challenge by any stretch of the imagination. And I'll be honest, because we're dealing with that in our particular client right now. And the reasons are really threefold. One, it's organizational. People want to protect their data. They want to be protective of it. They like the silos, even if it's in the EMR. There's people that own and manage and maintain and administer the actual application of the EMR, and they want control. The second, so it's organizational and political. The second is basically workflow related, which is sort of building on your other point. It's people don't know what to do with it. And that's where sort of the CIO office and sort of the executive office come in and say, we're not going to freely let you pipe into the EMR or other related ERP or enterprise-wide applications to pull that information because we're not going to know where it's going to go. And you lose control, you lose the auditability of it, you lose the traceability. The third issue is then basically just the application of it. So far, it's political, it's workflow, and then it's really the application. And the application is sort of paramount, right? Where you have people, again, going back to creating these different analytical, fiefdoms, and they're pulling information randomly from all over the place, and they're creating it, and they're using it in good purposes, but there's lack of consistency and harmonization and standardization across. So again, to answer your question, it's not technical, it's all of the other sort of, softer issues surrounding it. And the technology actually becomes easy, it's pretty, today, it's not that hard as you know, so.
Let me say a couple of things first. I work for a public limited company, so everything I'm saying is my opinions and not my company's. So somebody asked in the previous panel, what is big data? And I kind of jokingly quoted a Frank Zappa lyric from 1979. There's an album called Joe's Garage Act III, and I've mentioned this a couple of times before. These are actually lyrics by me, except the first two words. Data is not information. Information is not knowledge. Knowledge is not wisdom. And wisdom is not beauty. This is my man Frank Zappa. In 1979, understood big data than anybody else today. My mom and Edward Abrams, actually my mom is an English professor, not unlike the late Obanon thing. I'm just above average, I guess. Anyway, I don't know if you caught that joke. My mom's an English professor, and she said, hey, man, Frank Zappa, Edward Abrams actually heads the Personalized Medicine Coalition. Right? They both said, oh, by the way, this is not Frank Zappa. Actually, T.S. Eliot said this in the 1930s. Another play called The Door, by the way. They all have something with the door and the portal and stuff. That's the first thing. The second thing is a lot of people talk about scale. Actually, just another quick piece of information, EMC is a 60,000 person startup. We have companies like RSA, for example, VMware, Pivotal, which there's some Pivotal people here who are building a fantastic horizontal platform for the future. To me, it's a couple of things rolled in one. I already mentioned the law that was more important than the technology. Understand the law. The second issue is understand scale. So we have more than 250 customers in the core life sciences, genomics and proteomics within the life sciences space that hold more than 250 petabytes of data today. And of course, that's growing exponentially, geometrically every year. The other issue that's very important as we kind of move into this period of scale, both in analytics and in just holding enormous amounts of data, is what is the retention period of some of these data sets. I've done a lot of research on this, I could go on for hours. But on the average, I distinguish this between in-band and out-band. So in-band data is the data that's actually being processed. So in the radiology world, where I was for a long time, a radiologist wants the data within 6 or 7 seconds for that particular patient, if that particular patient is being treated. So in the US, I would say on the average, you can get away with 10 years beyond the last treatment date. UCSF will say otherwise. But if I go to Northern Europe and some other European countries, they keep their data for 50 plus years, depending on which country. Some countries like Norway keep it for much longer. I think Israel keeps it for 70 plus years. So there is, and somebody was talking about free the data, we were just having a chat. So you need to understand the context of what kind of data you're looking at. Especially in genomics and other places. I don't want to go too deep, but I'll stop there. You have to understand how fast you want to get the data back from your out-of-band data set and bring it to the in-band, so if the patient comes back in treatment. If it's a chronic patient, like I'm sure the orthopedic case is not quite true. Diabetes and heart disease, probably cancer, of course, depending on the kind of cancer again. So you need to understand the context of what you're treating and how long the data is.
Yeah, if I could just say about the patient care issue. What we do with all those things that I described, we have at least 25 variables that we consider gaps in care. we work on standards published by the National Committee of Quality Assurance, NCQA. And what we do now is we are able to import these gaps in care into all of our primary care offices so that when the patient is in the room, an alert is billed in the EMR saying, you are overdue for your colonoscopy. John Smith, I will write you a script today, and here's why it's important to have this test. So that's how, from the insured perspective, we can help our members get better care from integrating that data with their provider. So putting it basically into the physician's office when they get a pop-up on their screen when they're in the office. Another thing, speaking of readmissions, we have done extraordinary amount of analytics over our readmissions because for everyone, a hospitalization admission is one of the most costly things. So actually the best thing to try to do is to prevent the admission instead of actually, and the secondarily is prevent the readmission. But we have done a lot of modeling, and we built a predictive model that we've talked about at many different predictive analytics venues and such that we can, we take the data, and what the model actually shows is we can break sort of members into 3 different categories: high, medium, and low of your likelihood, your propensity to get readmitted. But when we correlate it with all of the clinical and the other data we have, one might think that people with the highest probability of readmission would be the most actionable members, but they're actually not. The people that fall in the middle group of the risk score of getting readmitted are the actual people that you can do some intervention with to prevent the readmission. The people that are in the high-risk category, there's nothing that you can likely do to prevent the readmission. They have a very high-risk score. So we have actually taken all of this modeling and built it into our care management system so that when we see an admission, every time we see an admission, it's given a score to the care case manager who's looking at it at the risk of being readmitted. And according to your risk of being readmitted, a potentially different intervention would be given to that patient, whether it be a phone call for education or a different type of discharge planning regimen when they get out of the hospital. So it's been very insightful, and we needed a big data to do that vast amount of information. We have to have a lot of admissions and readmissions to do that type of predictive analytics. So that's how we're using that data to really hope that it's going to impact the care of the patient.
Now, speaking of patient engagement, which we've touched on a little bit, what have you found in terms of directly engaging patients in your respective work? A lot is made of patient engagement in Silicon Valley, where many of us are in the activated community that has Fitbits and Jawbones, and we do biome tests and 23andMe, and we profile ourselves and we like data. But what about in
the working folk in the commercial line of business, that they can go in and look at their claims or do an e-visit or something like that. We have e-visits now. So I think patient engagement is a very big area that still needs to be explored, because if we can't understand, who responds best to what, we'll never really be on the target. And that's really, I think, an important factor in engaging people in their own care.
Can I add? So EMC is self-insured. And there's some very interesting experiments going on within the company. Like I said, we're a 60,000 person startup across 80 or 90 countries, something like that. In the US, I think, again, this is my personal opinion, I'm not endorsing any product or company. I have to say this, by the way, I have to take an SEC exam. So we just recently started a project with Castlon for the patients to be empowered. I ran a small business, unlike John, for 10 years. And when politicians say, "Oh, we're giving advantage to small business," I don't want to use any French words here, but I used to pay $1,700 a month for family health care. I reverse engineered Vista, by the way, which is the VA's healthcare system. So I can go in the weeds about why drug-drug interactions don't really work. But that aside, I think the issue of cost comes up so many times, especially if you're a small business. John's probably facing this as the founder and the president of this company, and it's not cheap. So the question of empowering self-insured, I'm sure this is where the major change is going to come, is by self-insured large companies that actually take care of their employees. That used to be the perk that you had good health care. I think I paid. I'm not going to tell you what I paid, but it's orders of magnitude lower than what I paid for a small business. So understanding what you pay for is critical. Everybody is so nervous to go and ask. I asked my physician, "What is your hourly rate?" We produce this when we do RFPs. The medical profession, I lived in Australia, I was telling somebody else that there's actually a salary cap in Australia. It used to be 140,000 Australian dollars. I think they've increased it slightly more. So I think the change will come from organizations that actually actively manage their own money. So let me stop there. So there's incentivization going on at multiple levels. It's an experiment, but I think companies that have large self-insured populations will big.
Now, on the flip side of this, entities such as UCSF might be dealing with the Silicon Valley-itis patient wanting to get their whole genome sequence when they're healthy and walking into someone like Bob Nussbaum's office, handing him a hard drive. Bob Nussbaum's the head of medical genetics at UCSF, handing him a hard drive and saying, interpret this for me. He actually went on last week at a conference about how this is actually a problem for them. So is there a flip side where there might be too much of an activated patient community that needs to be dealt with, and the medical system might not be suited to deal with this way?
I don't think there's too much. I think what we have to do, though, is calibrate realistically for people that having a lot of information alone may not actually help them with their decision making. So how do we help them get the right information, and then how do we help them, use the phrase again, contextualize it so they really want to make choices off of it. And we actually, believe it or not, even though we haven't done maybe historically a good job of empowering patients, we've always wanted to. It's an important part of the equation. And perhaps because I was a physical therapist first and did cardiac rehab for years with lifestyle modification, you have to try to figure out how to empower patients, or the outcomes just aren't going to be as good. We really do want to do that, and we're learning it. There's a science around it. One piece is information and education, but there are two other steps to it to actually have true patient engagement. We know when we get those, where we actually see behavioral changes, we know that it does translate to outcomes that we want, including readmission rates, certainly patient satisfaction, and decrease in the episodic crisis type management of the disease. So we know there are good things we've had. It's a science that we're working on. How do we do it? Information is absolutely a big first step, and framing it so that it can be understood in the cultural competency that's appropriate, as well as the other factors that tell us that we need to better understand each individual patient. By that I mean, I was asked to speak at Silver Summit at CES on, how do we get this population, the older generation, to adopt technology? And I said, well, first of all, is it a problem because it's changing so fast? I'm not sure that you're looking at today's data compared to yesterday's. It's the fastest growing segment of tech adoption, even though the numbers are absolutely so low than other segments. if a grandmother has a grandchild, she knows how to text. Otherwise, there won't be any communication because kids don't want to talk on the phone anymore. But what it really was, it's about knowing your audience. So if you reference this in the work that you've done in analyzing, do they want to be on the phone, do they want to do it via web? It's truly, we need to get a lot better about adding design thinking and analysis that goes into design thinking up front in the technologies and solutions that we're building, so that we actually know better who we're building to and for, and that we include them in the building process much earlier. So I do think patient engagement is critical. I think we're learning quickly how to get better at it, and I think we'll see good results from it.
And just to add on that, I think these are all good points, whether you're using it, through mHealth, mobile health, or you're building different campaigns and so forth. But I almost feel that, the healthcare community, when you're talking about information related to a patient, and I'm not talking about HIPAA or PHI, we have a social responsibility. And I think building on what Aenor was saying, it's that, there's a lot of information out there, it's information overload. It's pulling data from everywhere. It's from social media outlets, genomic profiles, and clinical, operational, financial data. And I almost feel like the recipient of that data, whether they're a patient in this case, feels that they have to have a trust. And this is more about the trusted transparency of that information. And I think the question is, what responsibility do payers and providers have to actually provide the right form, whether that's a website or an email or a phone call or some sort of electronic outreach program, to have making sure that you're not giving them too much information. You're giving them enough information to be knowledgeable, but not enough information to be dangerous. And the classic example comes to mind is when somebody sees a rash on their arm, the first thing they do is go WebMD and they start looking at a bunch of different pictures. Well, do they have the right knowledge to be able to accurately diagnose what it is and differentiate it and so forth? So again, it's more about a social responsibility in terms of engagement.
And one thing that I always like to ask is, can we talk about some failures? So we talk about failure to implement programs and potential lessons learned from those failures. And don't all rush up on answers.
I'm honest. What does failure mean? In the IT business, I was told many years ago, failure is when you go 2 times over budget and 2 times over time. And I've looked at many different projects, being the beat, belly of the beast, as we call it. The failure rate in healthcare IT, I heard, was in the order of 80%. Failure rate in general IT is between 30 and 50%, depending on who you talk to. Healthcare is complex, especially in our country. So I already mentioned my radiology experience. By the way, healthcare is a $1 billion business for UC. It's a fairly big piece of the pie. And I think we are trying to evolve along with the country. And yes, ultimately we would probably want a single payer model one way or the other. It's probably not going to happen anytime soon, maybe not 100 years. But if you look at other countries and who are trying to do this, even though Great Britain has single payer, maybe 2 with Bupa now, which is also private insurer, their technology, we are still the best in ratings in the US. So I think in spite of all the failures, I'm trying to kind of turn that around, we're still okay. I mean, we have 5 healthcare models compared to other countries, 1 or 2. And specific failures, I mean, I see this all day, every day. I mean, what does that mean? I think to me it's a continuum. And as we move forward with these massive unstructured data sets, by the way, there was a survey out by a couple of sources that the amount of healthcare data in the world, if you divide them into structured and unstructured, it's in the order of 75 to 80% unstructured and about 10 to 15% structured, something of that order. It's actually the structured part is getting smaller, obviously. So failure, I would ask John to define what failure means. So if it's just project in healthcare IT, yes, we failed quite a bit.
My failures revolve mostly around vendor implementations, to be honest. Sorry for you vendors out there. The vendor that I'm going to speak about, I would not name, but is not in the we build a lot. We have the capability to build, not just on the provider side, but UPMC as a whole. We are an integrated delivery system. We have a very robust IT team. We do build and develop a lot. We are even building and developing commercial applications. But in my group, we do build a lot of in-house to feed our own needs, especially on the back end in the databasing and the standardizing of data layer types of things. But a recent failure of mine, it was a little personally difficult to take because we invested over a year and a half of my team's, basically work life, not exclusively, to get this vendor application up and running, to do some of our, what we feel is very important, to do some provider, for lack of a better word, I will say profiling, to really try to bring transparency to cost and quality, primarily in the area of specialty care. There's a vast difference in quality and cost when you're looking at the specialists that practice in our widened geographical area. So we want, as an initiative, to be able to tell our PCPs from our perspective, based on X amount of instances, that cardiac surgeon X, Y, and Z, are efficient and are providing good care, financially efficient, providing good care. They're not over duplicating with testing and just wanting to bring them back in for office visits as they don't need. So we had a vendor failure with that. It was like trying to fit our data wasn't structured the way they needed it, trying to put a round peg into a square hole. We learned a lot of lessons from that. We realized we had to do some data cleanup on our end, really, to be able to fit any solution. And lucky for us, we found another vendor who actually was a smaller company, and we have had a successful implementation, and this product actually provided us with provider transparency, as well as replacing some of our risk scoring and predictive modeling on our patient.
Which basically means that people are going to do what they want to do and they control their own data universes. And I think that is more and more prominent in healthcare than in other industries, just because of the nature of what they do and the lack of integration that has historically existed. That's now changing and for the good. But again, that's sort of what I see as a general failure across the industry, and hopefully something that we're overcoming soon.
That's an overlap with what you say. And hopefully that's true, because we're working more closely together, which is great. I think where I see failures most often are failure. Patient satisfaction, the outcome, those are critical. We also need to know if it's cost effective, so that the wheels can stay on the cart, we can keep the doors open, we can deliver more care to more people and better care to more people. people. So just the analysis and the evaluation piece, I think in our own industry, we have more to do. I think in things that are being built outside of medical centers where there may not be as much experience or scientific rigor, I think we need to bring a lot more evaluation to the technologies that are being built. We need to look at the effectiveness in improving health and wellness and also the cost effectiveness. So twofold evaluation. So make sure that we're analyzing as we go along.
Can I add one quick, sorry. Can I have a quick note to that, the defense of vendors? I think it's all about requirements management, and
project that this particular vendor would not have been the right choice for us. But I think still in very big organizations, sometimes the information or the decisions are made at the C-suite, and they think that it's something that sounds like a good idea and will work, and maybe the price is right. But when it filters down to actually the implementation phase or the requirements gathering phase, it becomes clear that there's going to be a struggle to make it successful. So it's not that this even particular vendor's product couldn't be successful in other companies. They have been in many. In our particular company, if the right people were engaged, it would have become evident that it wasn't quite the right solution for us.
I think that feeds nicely back into the second point I was going to make. So a failure to analyze, I think, or a lack of analyzing has led to quite a few of our failures. But the other is a lack of alignment. And what I find exciting about this space right now in digital health innovation and the high-tech, health tech movement is the cross-pollination, the multidisciplinary aspect of this field, I think, is what's bringing the hybrid vigor that we so badly need. And I think that will work tremendously effectively as long as we can work on a specialty area called alignment. And you can imagine that when you bring in disparate fields, like I dearly love Andy Grove, and we're often speaking in the same room and maybe even at lunch, and he may be saying free the data, and I look down and I see 3 messages in my email that says you could personally be fined $250,000 for a HIPAA breach. And so trying to align these really polar opposite tensions that exist across fields, it's really important. It's important that we understand how to find alignment, even if it's dynamic. And this happens every single day, and I think if we approach each other from our disparate fields of understanding that each is actually earnestly trying to do the best thing from their vantage point, and what we need to do is come together and work together and find the alignment where it may not be very obvious in the beginning.
So to that point, before we open for questions, we're actually working with one major medical center where we've already been through our audit and InfoSec processes. We already have a BA in place, we already have a contract, we've already been paid, we've already started the implementation, but the guy who has the keys to one of the data warehouses will not open up the data warehouse because he says, I'm nervous about losing my job, losing my house, and being sent to jail for a PHI breach, and I want you to personally indemnify me that you won't get me sent to jail. So welcome to the healthcare world, folks.
Well, so I think that could be addressed. I'm sure you've been working on what you do. First thing you did was you identified what the fears are, because that's the hurdle. So as soon as you start trying to identify the hurdles if they're not, and then you figure out how you start to. But I think there's some answers there, but you've been working on it for a while.
Oh yeah, this wouldn't happen if we were developing Snapchat. All right, with that, we have about 10 minutes left. Let's see if there are any questions from the audience. There's a microphone up front. If not, if you want to stand up, shout out the question, we'll repeat it up here. And if not, I'm just going to keep asking questions until you get tired of it.
Everyone must be tired for the day. They want the happy hour to come.
Everyone is awed and amazed by how
Here comes trouble.
I put the red jacket to the foot of it. So there's a lot of startups with really cool technologies, and then they hit the selling cycle to the providers. So what can you think outside the box on how to basically identify the one it's worth your time to spend time, but also speed up the selling cycle internally so it's not 18 months, so they don't run out of angel monies or whatever little money they got, and the Series B, VC come in there to say, come back to me when you're $5 million in sales, and then he's expecting it for 5 years. So any suggestions on how we could change the system? And are you free to tap on that
question? Crowdfunding. I mean, I know a lot of wearable companies that have gone crowdsourced. I don't know if you have. Right? I'm assuming you're sorry.
So I didn't mean to crowdfunding, but how the providers can change the way they select the hospitals. Because right now, historically, it's 18 months, you have the Medtronic and all of that, and they have a sales force that can afford that. Startups cannot afford to do that. Things are changing too fast.
So let me make sure I understand the question. How can the provider,
Be faster at evaluating company.
from the payer? I'm from the insurance
Well,
side.
either way, technology is being used for you to impart the patient so that you decrease the cost of the insurance, and then Aenor from a provider point of view. I mean, there's a ton of startups trying to come up with cool stuff, and they're getting stuck into a long selling cycle.
Basically, when I come and call on you, how is it going to not take me 18 months?
Right, so I think you're saying if they're seeking paying customers, how can they get vetted faster and get adopted more quickly into a system where they might actually not be customer? For us, a lot of what's missing from outside technologies being built is the evaluation piece. So when they come to us, a lot of times they actually haven't been proven. And from either a cost-effective standpoint or from an actual healthcare change standpoint. So we're trying to, we work a lot with inside and outside incubators and innovators, trying to help them get more evaluation built into the development arc as they're doing it. And so I think that will help. So by the time they actually come looking for a customer, they can say, we've done this level of effectiveness in care, in health, and in cost. That will help a lot. Because you can imagine that we only have so much of a margin where we can experiment in healthcare. You don't want me taking a new instrument into the OR every time, even though I like innovation and I do like to try and fail and iterate. I don't really do that with my patients. And so the safer it seems and the lower risk it is, just like to an investor, that it is to a person who's going to use it in the care mode, the more quickly it will get adopted.
Can I add one more thing? So I've actually been on panels with Aetna and Blue Cross Blue Shield, if I can say that right. They all have venture groups. They all have venture arms. And a fairly large insurance company, United Health, has a lab called Optum Lab. Again, I'm not vouching for any companies anymore. So this is just hearsay from people I've been with, that there are people on the other side of the fence trying to make sure that technology is used correctly and as a partner to newer ideas. There was a whole panel on innovation this afternoon. So there is a possibility, you just have to know the right thing. So.
Yeah, it is hard. We do have a venture arm as well. We have international services. We have something called the TDC, the Technology Development Center, working on a lot of novel applications and really better how to pull relevant information out of charts, getting a chart, getting it stored electronically. But I think generally it is, as she said, you have to. I think it's difficult when you have to have somewhat of a proven track record, because I don't think from even an insurer perspective, you're not going to go out and invest hundreds of thousands of dollars on a technology, even if you feel that you need it, unless you can call your friend at Insure X, Y, and Z and said, what is your experience with these guys? Tell me your other clients. So I think it's very hard to break through. But even as we were just talking, Jonathan might have a sort of a little niche that I need, and that hasn't been necessarily explored from the health insurer perspective, and I definitely want to talk to him about this. So I think if you're really hitting the niche, we'd be willing to go out and go out on a limb and try to partner. Sometimes the way we do it is we'd like to explore partnership with the startup instead of just saying, we'd be a customer. So, but it is.
Conference.
I was just going to add, come sooner when the pilots and evaluation need to be done. We want to partner with that. We want to get more clinical input early enough and make sure the design thinking is in there, which is all the focus user groups, even the lean launchpad method where you're interviewing a lot early on, so you understand, is this a real white space? Is this a real need? And is my solution really going to solve that? Those things really help when you go to sell something, right? And it's not different really than trying to sell other things. It's just that the ability to risk is lower in the margin.
Conferences like these are a great venue. Serendipity is sometimes the best provider in new business. When I was in startups, there was a guy who was running a flow cytometry project for the immune tolerance network, which just happened to be the same conference I was. There you go. That was a big project.
So I'm hearing more about the care improvement from the provider side and the cost and how care improvement, what it means to the provider. I'm trying to understand the patients and the caregivers and how you actually look at the lens of patient satisfaction using data and analytics to improve their perspective of their care.
That's interesting. I actually haven't talked about the provider experience today. Most of my remarks are about the patient experience. We're actually not doing a good job measuring the provider experience, and one concern is that there's going to be a shortage of physicians coming because the experience of providers right now is a little bit rocky with some of the changes that have come. But I want to say that from a patient experience, that to me, that's what I thought I was primarily speaking about, and we do care a lot about it. Not just because we have Press 80 scores and there's now reimbursement attached to those things, but we do know that a patient who's more engaged and more satisfied with their care and more trusting of their provider does do better. Even if better means they don't survive their disease, the pace with which the disease progresses is much improved if those things are in place.
And from my perspective, we do a lot of random surveying of our members. So we are very focused on our member satisfaction, obviously, because the members in our area, they have choice. We know they have choice. We want there to be choice in competition in the market. So we routinely ask them about their satisfaction with us, their customer service, with our formulary. Are they also satisfied with their provider, their specialist? And we analyze that data, and most of the dissatisfaction lately has come with actually changes to the formulary, and the cost of medications is a big one in my geographical area. We have a large focus on, like I was saying, building patient medical homes, and a lot of interaction with our providers, especially PCP. So people are generally very, very satisfied with their providers at the UPMC, but on a cost perspective things, obviously there's going to be some dissatisfaction.
I also think that, to your point, we probably don't know nearly enough on how to ask questions or help patients articulate what it is that is satisfying to them or meaningful to them. So there's actually a steady body of work around how do we help people define what is quality of life for them. I referred to scores that we already have, but I think there's a lot more work that needs to be done in helping people voice and express, and us to, in some kind of an analytical way, incorporate patient preferences into their care overall.
I think there's also some effort going on in sentiment analysis. I don't know if you've been through an airport, I fly a lot. So some airports actually have fairly detailed scores, but there's 5 levels of happy face to angry face. If you like the airport and various other things. It's actually coming in healthcare as well. I know 3 companies, I won't mention their names, but this market is actually one area where investors are pretty interested. Is, there's a time axis involved as well. People who go out of a procedure or outpatient or inpatient, as soon as they go, they have a certain opinion, good or bad, and then if you ask them several months later, it may change. So that trending and that longitudinal issue for even the patient response. I always say, in the end, all these are tools. Hopefully, the tools make the patient's life better. So you should never forget.
Just to build on your point, there's also the whole notion of lifestyle analytics, which is taking a lot of traction. And this is really more the integration of all of the information around a patient's experience. So it's looking at trends from retail, like where do they shop and where do they eat, and what's specific about their neighborhood, and what gyms do they belong to, how often do they go to work out, and the weather is like. So I think more and more we as patient consumers, if you will, are really demanding more of a holistic approach to saying, yes, I treated you for this, I gave you these drugs, but I also can give you recommendations, right? And those are all the variables that help affect the experience of having positive.
Just one thing to add to that too is that the ability to make it flexible for patients. So we have a project called Prepare, where it takes patients in a web-based portal now, soon to become mobile, through the difficult decision-making processes around end-of-life care and end-of-life choices. But rather than have it happen on a gurney in the emergency room when they're febrile and they're 87 and someone says, you don't want a tube put down your do you, and you don't want someone to come on your chest for you. Instead of taking it in that framework, we're now letting people, because of technology, do this in a setting where it's more comfortable with people that they love in their own time frame. So allowing those processes of decision making and understanding of those things to happen in a variety of settings rather than just on our timeline in our framework makes a big difference.
Any other questions? If not, since I know 2 of the panelists have a plane to catch, I think we'll just end here. And thank you all for your time and attention, and joining me. Thank you, the panelists.
Thank you, John, for a great host.